Good morning. I want to thank Rochelle, Dr. Winnicott, for inviting me here. Beautiful city, thank you. And it's my great pleasure to introduce our next speaker. So Dr. Garvey is an emeritus professor of medicine and laboratory medicine and pathobiology at the University of Toronto, and she is a very wonderful person who was the founder of the Comprehensive Care Haemophilia Program at St. Mike's Hospital, and the largest adult program in our country. She's authored over 100 papers, and one of her great contributions is that she's done wonderful work in Jordan through the twinning program. And Dr. Garvey worked on this with Dr. Eliana Seidenberg, who unfortunately is ill and cannot join us today. And Dr. Seidenberg is director of the blood bank at Ottawa Hospital and made a tremendous contribution to this talk today.
Thank you very much. I hope you'll excuse me for giving this talk sitting down. It seems every time I get involved with hemophilia, I either break a bone or get something. And I was in the meeting in Scotland and got pneumonia, so I'm still a little weak in the legs. So I'm going to do this sitting down if you don't mind. I would want to point out that this talk originally began with Dr. Seidenberg. Dr. Seidenberg is unfortunately unable to be with us today, but I would like to acknowledge her input into the work. I'm going to speak on the, neither myself nor Dr. Seidenberg have any conflicts of interest. I'm going to start the talk by just a very brief clinical patient who has, just to point out some of the difficulties that can occur with lab testing and with not actually knowing a great deal about the patients that we sometimes are presented with. This is a case of a 29-year-old woman who appeared in her first pregnancy in the 18th week. She gave a history of epistaxis for 4 years, 4 times a year into her high school days, and she was then put on oral contraceptives after menarche when her cycles were very irregular and very heavy. She remained on oral contraceptives throughout all of those period of time. The flow was lighter. She had no problems. She did say that she bruised easily. She also said that she had problems with minor wounds, but she never saw a physician for any of these issues. She had one tooth extracted. There was some packing, but there was no excessive bleeding. Now, you have some cards in front of you, and I would ask you, those who think that she needs further lab testing, would you put up a red card? And those who think she doesn't, a green card. Everybody thinks she needs further testing, which surprises me, actually. Why doesn't it? Oh, there we go. The obstetrician, being a wise person, took a good history from this patient. The patient's mother and her maternal grandmother both had experienced heavy menstrual bleeding, and an uncle of the grandmother died following tonsillectomy in childhood. So she did undergo additional testing. It was found that her von Willebrand's antigen, her von Willebrand's activity were both normal. Her factor VIII and her factor IX were also normal. So one had to consider what additional testing would be recommended. We don't have a lot of time to go through each of these points, but it was elected to do genetic testing for factor VIII. One could consider whether genetic testing for von Willebrand's disease would be appropriate, given that it is quite common. But the fact that this woman had absolutely normal findings during pregnancy was important, and also the fact that factor VIII, genetic testing in factor VIII for factor VIII is very well established. There are a lot more difficulties in interpretation and doing genetic testing for von Willebrand's disease. What was found that she did have gene analysis revealed the presence of a mutation known to be associated with moderate hemophilia A. Now, why does it matter in this woman that we know this in her prepartum period? She seems to be perfectly fine. Her factors are all normal. She has a factor VIII, a von Willebrand's antigen, which are both within the normal range. She is able to, we would recommend that she deliver normally. But neuroaxial anesthesia is a little bit iffy if her factor VIII is only around 50%, but I think we're going to hear more about that this morning. But it is important that we recognize the sex of the fetus because this woman is a carrier and may very well be carrying a hemophiliac baby if it is a boy. So it is very important as much for the mother as for the as much for the baby as it is for the mother, although, again, the mother needs to be followed in the postpartum period, another topic that we'll be hearing about again later in the day. So when it comes to laboratory testing for bleeding disorders in women, what's the problem? Why is it any different than it is for other people? Well, actually, the testing isn't any different. It's just that it is required more frequently. And we know that the vast majority of causes of heavy bleeding, particularly menstrual bleeding in women, is gynecological. It isn't due to a bleeding problem. And when people are seen in coagulation clinics referred for assessment of bleeding, abnormal bleeding, there's the vast majority of those patients seen no bleeding abnormality can actually be detected. And if you talk to your colleagues, many of whom will probably, hopefully will agree with me, or you look in the literature, somewhere between 20 to 50% of patients that are referred for really assessment do not have, or no bleeding abnormality can be identified. Is that because we can't identify it, or is it because of what who's being referred? So what are the issues in approaching testing? Who, what, when, where, how? Well, who? This is really a really important point for people in laboratories. A good medical history is essential. Who should be, many women will state that they have heavy menstrual bleeding, and as has been pointed out, there are ways of diagnosing this. But who should really be tested? Women who have a poor quality of life due to menorrhagia, postpartum or surgical bleeding without good explanation, cutaneous bleeding, nosebleeds, tonsillectomy, bleeding with tooth extraction. If there's a family history of abnormal bleeding, or if there's iron deficiency with heavy menstrual blood loss, I think people who are significantly iron deficient and complain of menorrhagia should be tested. Now, you've heard recently, which is going to become more prevalent throughout the community, but certainly isn't universal throughout medical care in this country, and that is the use of the BAT score. And those that are positive, we would look at it. Those people should also be assessed. But we've heard quite a bit about how many people with von Willebrand's are not diagnosed appropriately, but I would put it to you that type 1 von Willebrand's disease may also be one of the more overdiagnosed problems that we see in the community, and telling a young woman that she has a disorder that she may not have at all is certainly not a very good thing and leads to concern in the woman and also to unnecessary treatment. I'd also point out that there are a lot of vascular disorders that can lead to abnormal bleeding in women, and I think as hematologists, and I don't want to speak for us all, but I have a lot of years behind me, we're not very good at taking history and seeing whether somebody's an India rubber man or they've got hereditary telangiectasia or other causes that can cause abnormal bleeding that have not anything to do with the hemostatic system. Now, where is also very important. We think that we've got universal health care in this country, and fortunately we do. God knows what's going to happen in Ontario. I guess I shouldn't say that. Sorry. With our next election, but at the moment we have universal health care, but your location definitely makes a difference in how well you're going to be managed. Many tests, I would put it to you, most of the tests which are done in a good coagulation lab are best done when the patient is either in the lab right with you or in close proximity to the lab. Access to laboratories with highly specialized care is not universal throughout this country. Many people live in remote areas. And in coagulation studies, the integrity of the specimen is paramount. And no matter how much you tell the commercial lab that is bringing the specimen to you, or the peripheral hospital which is sending the specimen to you, you don't really have a good control over procurement, over handling, over transport. And those are very important issues in doing good coagulation testing. The second thing we don't always have good control over in hemostasis laboratory is, again, a good and thorough history. There are many levels of coagulation factors, especially factor 8, von Willebrand's factor, fibrinogen, all vary with things like the menstrual cycle, with pregnancy, with oral contraceptives, with stress, and people have to go to a hospital in a major city, have come from a small remote area, may be under considerable amount of stress when they arrive in the lab. Exercise, inflammation, and as we're all aware, people with blood type O have different levels of von Willebrand's factor and of factor 8. I just want to say a little bit about age, because von Willebrand's factor, the most common cause, as you know, of bleeding in women, von Willebrand's factor does increase with age, but that probably doesn't bear a major role, as menorrhagia is not an issue in the elderly. But I would make a point that we should be careful about doing a lot of laboratory testing on young women who really are totally asymptomatic. Levels also vary with a number of diseases like thyroid, renal, and liver disease. And therefore, I think we should look at many of our coagulation tests and say they should be done on more than one occasion, unless you have really good control from your referring physicians of the history of all of these factors, which I would put it to you, we don't always have that good control when you have specialized labs where things are sent from peripheral hospitals and through commercial laboratories. Now, how? There's a lot of coagulation factors, coagulation tests. I only have 20 minutes. They're going to be gone through very quickly. Abnormalities or defects in the plasma coagulation factors that we're all familiar with should be able to be identified very accurately at any good coagulation laboratory with good quality control. Carrier status could be problematic when factors are very close to the normal range, and more thorough investigation may be done at that time if people come with a history. There's also pitfalls. One has to be very careful when you make assessments on coagulation studies which were done outside of your own laboratory, because there are certain variations in testing. For example, one-stage assays of many of the factors have different levels than chromogenic assays. And also be careful to remember that factor 8 may be lowered by a low von Willebrand's factor, and therefore someone may be misdiagnosed as a hemophilia carrier and treated as such for that reason. Now, for screening for von Willebrand's disease, I think first let me say that we diagnose in laboratories, diagnose people correctly, we diagnose people well, we diagnose lots of people. So one shouldn't get depressed when you look at the multiple things that can happen when you're in a coagulation laboratory, and there certainly are multiple defects which occur. For von Willebrand's disease, of course, there's no single diagnostic tests. Tests are, no matter how much ISTH works at it, tests are not well standardized and do not necessarily correlate well with genetic defects or bleeding. The typical screen for von Willebrand's disease, the most common disorder that we're looking at, is a von Willebrand's antigen, a cofactor, and a factor VIII. In areas of von Willebrand disease where one may feel that there is an decreased survival of circulating von Willebrand's factor, a propeptide may be useful, but this is not done in all laboratories, in fact, not in many laboratories. Screening tests, again, as I said before, must be interpreted in the light of a good history. And I think the BAT score is going to help a lot in that area. Now, there are a significant number of people that are tested that fall outside the normal range. And if you look at people with absolutely no bleeding history, they may well fall outside the normal range. And therefore, laboratories that, to whom a lot of patients are referred probably should have a different normal levels for people with type O blood, factor VIII, and von Willebrand's factor. But even doing that, there are about 3 to 4% of people who have absolutely no history whatsoever of bleeding abnormalities who will have coagulation factors, basic coagulation factors outside of the normal range. What about screening for platelet disorders? This is complex and it's often timing consuming, and there's no good global test for platelets given their multiple factors of adhesion, aggregation, and secretion. Being hematologists, even we often do not take the time to look at platelet morphologies. Looking at a peripheral blood film may help you in finding abnormal platelets in a number of inherited bleeding diseases. And if you can persuade your anatomical pathologist to give you a hand electron microscopy of platelets is very useful in looking at granular contents of platelets. Flow cytometry is also useful when looking at, particularly looking at the glycoproteins on the platelet surface, but it is becoming much more utilized in looking at a wide variety of platelet abnormalities. But it is, flow cytometry itself may be relatively available, but the interpretation of flow cytometry on platelet deficient defects is a little more difficult. The important thing about doing screening for platelet disorders is to remember that there are many medications that have effects on platelet activity, and over-the-counter medications are extremely important to get a really good history. Most people think if they buy something over the counter, it isn't really medicine, but the fact is that there are many medicines that have antiplatelet effects, which are over-the-counter drugs, and those have to be looked at in screening for platelet disorders. Now, what about the test that is present in many laboratories, not only in highly specialized coagulant hemostasis laboratories, that is the platelet function analysis. This it's useful, but it can be impacted by many factors which we have to be aware of: low hematocrits, low platelet numbers. It is useful, however, that it can be said that somewhere between 60 to 70% of von Willebrand's patients in a much wider area of inherited platelet defects can be picked up on screening with the PFA, and abnormal results should then prompt repeat and further investigation. It is sensitive to low von Willebrand's factor. A normal PFA, however, does not rule out von Willebrand's disease. I'll just mention that there are point-of-care testings of platelet function. These are usually not used in diagnostic purposes, but more frequently used for patients who we're looking at on antiplatelet medications, and they come with their own So it is said, I mean, a PFA can be used in any, really they're widely used. We have experts in this group on this technology, but it isn't absolutely foolproof. And it is said that if you do a PFA on someone 3 times, you'll probably get at least one answer that is unlike the other 2. The really important thing here, again, is to look at drugs and look at drugs that have cause abnormal platelet function. The gold standard, however, looking for platelet functional disorders is the light transmission aggregometry, fairly commonly used methodology. It is sensitive enough to exclude many inherited platelet disorders. It is said in the literature that up to 40% of patients with inherited platelet disorders may have normal aggregometry. This depends, of course, a lot on the number of agonists used, and it is recommended that a large number of agonists be used. Again, I think that we could improve that considerably by being much more careful on the patients who are assessed, and therefore platelet aggregometry needs to be done when the patient is really fairly close to you, because it should be done within at least 3 hours of the specimen having been taken. Again, one has to be very careful about that the patient is fasting, that they've been off all drugs that they can possibly become off for a week, approximately a week prior to being seen, and therefore careful and that the blood be taken in a very atraumatic manner. So if platelet aggregometry is definitely best done when the patient is right within your laboratory or very close to your premises, at least within your institution. Lumi aggregometry is not universally done. It is preferable to light transmission. It's not as sensitive, but it can measure abnormalities in platelet secretion, which are important components of hereditary platelet disorders. The ricocine cofactor we've noted is part of the workup of a screening test for someone with von Willebrand's disease, or suspect von Willebrand's disease. It can be done manually. It is now automated on many of the equipment, and the automated ricocine cofactor, while not quite as sensitive, is a lot more stable. Manually, it has a high coefficient of variation. It may vary with the batches of ricocine, and there's some instability in the assay. Also, one has to be aware that sequence variation in the von Willebrand's protein can lead to abnormal results without testing. Newer and more sensitive ways of measuring this, looking at glycoprotein 1b in the ricocine cofactor, will improve. But if you look at your quality assurance in a good coagulation lab, the ricocine cofactor is relatively a stable test. What about collagen binding? Looking at the ability of von Willebrand factors to bind to collagen. It's not done as a routine in many labs. It is dependent on a lot of variables such as Multimer size. It's also dependent on the source of collagen. Collagens type 1 and 3 do correlate better than other collagens, and the other collagens which are required in doing this test are sometimes not readily available. Multiple analysis, of course, I personally think probably is best done in a laboratory who does a lot of it, because there's a lot can be learned from multiple analysis. It looks at the von Willebrand's multiples and allows us to differentiate between one type of von Willebrand's and another. It's a little bit difficult to set up, and it does require expertise. It looks very simple, but does require some expertise in reading. but once established is very useful in defining von Willebrand's type. I think the important thing about von Willebrand Multimer analysis is that high molecular weight components of von Willebrand's can be lost during a variety of things such as a cardiac valve disease, congenital heart disease, but improper specimen handling, rough handling of the specimen can also lead to loss of multimers. So again, because these are often sent out, one has to be careful about how they are how the blood is procured and delivered. The ricocene platelet aggregation is not done widely. It's difficult to do, and it looks at the affinity of von Willebrand's factor for the glycoprotein on platelets, but a very fresh sample is absolutely mandatory and therefore needs to be done when the patient is in the laboratory or in the hospital with you. What about rare bleeding disorders? We know that there are multiple factor deficiencies. Most of these should be able to be picked up within any good laboratory. I want to mention particularly fibrinogen or abnormal fibrinogens or abnormal or afibrinogenemia, and probably factor 13 should be put in here too, a little more difficult to do than the regular, but not the regular factor assays. You should be able to pick up an absent or an abnormal fibrinogen within a good laboratory. However, if you find an abnormal fibrinogen, genetic testing is probably required in order to identify exactly the variant that is present. There are people, very rarely, abnormal tests of fibrinolysis. Again, abnormal fibrinolysis, if you're looking for it, could be picked up on your ROTEM or something as simple as euglobulin clot lysis time, but these are not readily done unless somebody really thinks about them. Now, what about genetic testing? We are fortunate in this country to have a highly specialized, reliable, and cooperative genetic testing laboratory. This does require a specialized, probably more than one, specialized laboratory. Till recently, these tests were very time-consuming and very expensive. They still require a high degree of skill, but with new glycoprotein sequencing, this has improved the rapidity of investigation and has reduced the cost, so these will become more available. Caution should be exercised in investigating asymptomatic family members with genetic testing, as this may bear on their further ability to in employment or in obtaining insurance, and one should be careful not to test people that don't need to be tested. They are, however, essential often in prenatal testing. So genetic testing is not required if a clear diagnosis has already been made. Probably, maybe there are those who would like to comment on this, but this is the last slide. Testing for coagulation factors such as 8 and 9 have been done for a long period of time, and we all do them quite frequently. Testing for von Willebrand's disease is much more problematic. Multiple sites are affected, but not all correlate with bleeding phenotypes. There's great variability in the von Willebrand disease in healthy individuals, and there's poor correlation between von Willebrand sequencing, particularly a wide variety in type 1, and has been previously mentioned, may overlap with type M. A third of patients seen with von Willebrand's disease do not have specific variants. But it is useful. There are registries available, and anything that we add to the registry will be helpful. So thank you.
Thank you so much. This is one of the most difficult areas for all of us, but in the interest of time, we'll just have one question, please. So Anybody have a question?
I had a question. So I think one of the things we struggle with as clinicians is how far to go when you really think that somebody has a bleeding disorder. So we talked about stepwise, we talked about doing the von Willebrand profile, and so many times we come up empty, and we're convinced that the patient has a bleeding disorder. So I'm going to ask the question is, what do you do in those cases? How far do you go?
Well, I mean, that is a difficult question. I mean, I think what was said is that the history is really, really important. And the VAT score is very helpful. And if one is convinced that there is a bleeding, then I think you go as far as you can. And I think this has to be done even within highly specialized hemostasis laboratories within this country. There are certain tests where one may need help from areas that are totally highly specialized. But if one is convinced there's a bleeding problem, hopefully one that you can do something about, I think you should go. I think the problem is testing too many people that don't have a bleeding problem. So I don't want to be on the other side of the fence. We think we're missing a lot of people, and we are maybe overdiagnosing a few people too. Okay?